Good evening. Today we will be discussing about quick revision series in medicine for the subject of neurology. So this will be useful for people preparing for competitive exams like NEET or NSET. So we will start our discussion. So first we will discuss about localization in neurology. So if you see the neuraxis, from above downwards it is coming like this. There is the cerebrum or the cerebral cortex, then some subcortical structures are there, then there is the brainstem, it ends in the spinal cord, and from the spinal cord the nerves come as the nerve roots, then they form the nerves, and through neuromuscular junction they connect to the muscle. Usually they divide the entire thing into upper motor neuron and lower motor neuron. That is for motor pathway. Okay, like motor system starts from the cerebral cortex and it goes through the internal capsule, through the brainstem, it ends in the spinal cord. From the spinal cord, the anterior horn cells are the motor cells. They start taking over, and from that the nerve fiber then continues through the nerve and to the muscle. So the corticospinal tract is called as upper motor neuron. The remainder of the pathway from the anterior horn cell till the muscle is called as lower motor neuron. This difference is very important when we are trying to localize a weakness. Okay. So we'll see how the manifestations of the particular part of the neuraxis will be. Cerebral lesions can present with altered mental status or coma, or that could be cognitive impairment, that is they can present with dementia. Seizure is one abnormality of the cerebrum. There could be unilateral weakness, hemiplegia or hemiparesis, like that. Then there could be visual field abnormalities and movement disorders, right? So many of these things we are going to discuss in subsequent sections. We'll take one example now. So movement disorder. So cerebrum has many parts again. There is the cerebral cortex, which is the outermost part. Then we have some subcortical structures like the internal capsule, the basal ganglia. These are some of the parts of the cerebrum as such. So I told you basal ganglia is one part of the cerebrum which helps in some coordination of movements. When basal ganglia is problematic, it produces many abnormal movements. For example, we know the very classical disease, Parkinsonism. Parkinsonism is a disease where subthalamic or substantia nigra, it is a part of the basal ganglia. It loses its dopaminergic neurons to cause reduced movement. Parkinsonism is a very famous hypokinetic disorder. Similarly, many hyperkinetic disorders also can occur due to basal ganglia. For example, chorea. Remember C for C. Caudate nucleus lesions cause chorea. So chorea is like a dancing movement. One classic disease is Huntington's chorea. Chorea occurs later. There can be suicidal tendencies, and it is one of a disease caused by trinucleotide repeat sequence. Then there is another movement disorder called as athetosis. It is like a slow breathing movements, like a worm-like movements. It is due to a problem with the globus pallidus. It is also a part of the basal ganglia. We have something called as hemibalismus, which is a flinging type of movement. It is a problem with the subthalamic nucleus. And we are discussing that classical Parkinson's disease is due to a problem with the substantia nigra pars compacta. Pars compacta is a part of the substantia nigra. So a reduced dopamine in the substantia nigra leads to Parkinson's disease. So we'll be discussing about Parkinson's subsequently. So why we came here is we were taking an example of how diseases of the cerebrum can manifest. So basal ganglia lesions can present with hyperkinetic disorders or hypokinetic disorders. So remember chorea, athetosis, balismus, where is the lesion? Okay. Now, when we come to brainstem, how does brainstem disorders manifest? Brainstem disorders can manifest as cranial nerve abnormalities. So brainstem is of three parts: midbrain, pons, and medulla. Of the 12 cranial nerves, the third and fourth cranial nerve originate from the midbrain. The fifth to eighth cranial nerve originates from the pons, and the lower four cranial nerves, that is 9 to 12, originate from the medulla. So the third nerve is called as oculomotor nerve, fourth nerve is the trochlear nerve. So these two come from the midbrain. Oculomotor, I think we'll take it separately. So from the midbrain has the third nerve nucleus. So the third nerve originates from it. Third nerve is called as oculomotor nerve. Fourth nerve nucleus is also in the midbrain. It is called as trochlear nerve. So these two have an important function in eye movements. So these are the two cranial nerves which have their nucleus in the midbrain. Now I told about pons. It has the nucleus of fifth nerve, sixth nerve, seventh nerve, and eighth nerve. They say eighth nerve comes actually from the pontomedullary junction, but it is technically taken as pons. So fifth nerve nucleus gives rise to fifth nerve, which is the trigeminal nerve. Sixth nerve nucleus gives rise to the abducen nerve. Seventh nerve nucleus gives rise to the facial nerve. Eighth nerve is the vestibulocochlear nerve. Trigeminal nerve has three divisions. As we know, it is ophthalmic division, maxillary division, and mandibular division. The mandibular division supplies the muscles of mastication, helps in chewing. The entire all other nerves of that is part of the mandibular, the maxillary, and ophthalmic carry sensations from the face. So trigeminal nerve is mainly for facial sensations and muscles of mastication. Do not confuse it with the facial nerve. Facial nerve supplies the muscles of facial expression. Muscles of mastication is by trigeminal nerve. Muscles of facial expression is by the facial nerve. Also, they have some other functions. For example, some important glands like the salivary glands, lacrimal glands, these are controlled by the facial nerve. Abducen nerve, it also helps in eye movements. Eye movement, specifically abducen nerve, has only one function, which is abduction of the eye. Abduction of the eye. Vestibulocochlear nerve has two parts, vestibular nerve and cochlear nerve. Vestibular nerve deals with balance, and cochlear nerve is for hearing. The lower four cranial nerves have their nucleus in the medulla. The 9th nerve nucleus, 10th nerve nucleus, 11th nerve nucleus, and 12th nerve nucleus. 9th nerve nucleus is the glossopharyngeal nerve, which carries sensations from the oral cavity and pharynx. 10th nerve, 9th and 10th nerve are usually taken together. 10th nerve gives rise is the vagus nerve. So again, it has very important role in parasympathetic function. It has a very long nerve supply even up to the GIT, up to the transverse colon. 11th nerve is the spinal accessory nerve. It supplies two muscles, sternocleidomastoid and the trapezius. The 12th nerve is the hypoglossal nerve, which helps in tongue movements. So we have 2 cranial nerve nucleus in the midbrain. We have 4 cranial nerve nucleus in the pons and 4 cranial nerve nucleus in the medulla. So any problem with the brainstem can lead to cranial nerve abnormalities. We have another peculiar syndrome called as crossed hemiplegia or crossed hemianesthesia. So what is this concept is? Shortly I'll show you a cross section of the brain, cross section of the brainstem. Like if you consider that this is brainstem, there is the pyramidal tract. The corticospinal tract is also called as the pyramidal tract. The pyramidal tract crossing occurs at the medulla. So the corticospinal tract fibers also run through the brainstem, and subsequently close to them only the cranial nerve nucleus will be there. So when a part of the brainstem is involved, it is natural that the cranial nerve nucleus is affected. Also, the corticospinal tract is also affected. So remember, corticospinal tract crosses occurs only at the medulla. So when there is a lesion above that, for example, if there is a lesion in the pons or in the midbrain, or even in the upper part of medulla before the pyramid formation, when there is a lesion, assume that there is a lesion in this part. So what are things can happen? The cranial nerve of that particular side will be affected, plus the corticospinal tract of that side will be affected. But we know that the corticospinal tract crosses and supplies the other side. So we will have ipsilateral cranial nerve symptoms, and we have contralateral hemiparesis or hemiplegia. So the presence of ipsilateral cranial nerve symptoms and contralateral hemiplegia is called as crossed hemiplegia. Always remember, when you take a cross section of the brainstem, the motor fibers are always medial. Remember M for M. I'll show you diagram subsequently. So the medial part of the brainstem always have the motor fibers. The lateral part always has the sensory fibers. So assume the same lesion occurs a bit more laterally, we'll have the same syndrome, but in this case motor fibers will not be involved, but sensory fibers will be involved. So there will be ipsilateral cranial nerve symptoms plus contralateral loss of sensation. So that is called as hemianesthesia. So that is called as crossed hemianesthesia. So whether it is crossed hemiplegia or crossed hemianesthesia, it means part of the brainstem is involved. So one example for crossed hemiplegia is something called as Weber syndrome. So Weber syndrome is a problem with the midbrain, where the same thing occurs. We know very well that the third nerve nucleus is present in the midbrain, plus corticospinal tract is also present in the midbrain. So when these two are affected, there will be ipsilateral third nerve palsy, that is ipsilateral oculomotor nerve palsy, plus there will be weakness in the opposite side, that is contralateral hemiplegia. Third nerve is also motor nerve, so that's why these two are medial, so we'll have this feature. Now an example for hemianesthesia is the Wallenberg syndrome, also called as lateral medullary syndrome. The name itself says lateral medullary syndrome. So when we go lateral, we will not have motor fibers. Instead, we have the spinothalamic fibers. Spinothalamic fibers are the fibers which carry sensation from the spinal cord to the thalamus. So part of the spinothalamic tract will be involved. The spinothalamic tract crosses above. So spinothalamic tract is involved, plus some of the cranial nerves are involved, especially the 9th nerve, 10th nerve. These are mainly sensory fibers, so they are present in the lateral part. So when these two are involved, we will have ipsilateral 9th and 10th nerve palsy, plus we will have contralateral hemianesthesia. That is about the crossed hemiplegia or crossed hemianesthesia. Now spinal cord can produce back pain, tenderness, there can be weakness, especially paraparesis. Paraparesis is weakness of both lower limbs. When it is complete absence of power, we call it as paraplegia. Whereas when it is involving the cerebrum or brainstem, there can be hemiparesis or hemiplegia. Especially when we go higher up, for example, involvement of the cerebral cortex will produce only monoparesis. Monoparesis can also occur in nerve lesions or plexus lesions, but monoparesis can also occur in cerebral cortex lesions. So that is how we decide the site of lesion based on the scenario. And when the spinal cord is involved, usually bladder and bowel disturbance, autonomic nervous system problems will be there. So root will cause typical radiating pain, the pain which is commonly seen in sciatica, the shooting type of pain. There will be loss of reflexes, weaknesses. Peripheral nerve is a mixture of everything. It has motor, sensory, and autonomic. So when a nerve is involved, in the place where the nerve is applying, there will be loss of all these three things. So there will be weakness, there will be sensory loss, and there will be absent reflex, autonomic nervous system. So neuromuscular junction is very important because it produces something which is peculiar. It's called fluctuating fatigable weakness. Remember, neuromuscular junction or a muscle lesion will produce only motor symptoms. It doesn't have sensory symptoms because the nerve itself is neuromuscular junction and it's muscle. Only motor weaknesses will be there. The neuromuscular junction, that lesions will produce fluctuating fatigable weakness, which is commonly seen in myasthenia gravis. So we will discuss that also subsequently. And muscle lesions also will produce only muscle weakness. There will be sparing of sensation. The common muscle diseases are muscle dystrophies. Muscle dystrophies are congenital conditions or genetic conditions where there is weakness of muscle. We can take one example as Duchenne's muscle dystrophy, Becker's muscle dystrophy. We have myotonic dystrophy. These are some disorders called muscle dystrophies. But there are some disorders called as myopathies. That is, any other condition other than congenital which is damaging the muscle is called as myopathies. There are toxic myopathies. Example, taking atorvastatin or any statins can cause toxic myopathy. Some metabolic conditions like Cushing's syndrome can cause myopathy. Some nutrition deficiencies can cause myopathies. So myopathy is different from muscle dystrophy. So this is just a gist. So in our entire coming session, we are going to discuss only these things. Okay. So we have cerebrum where there is seizure, coma, cognitive disturbances, movement disorders or monoparesis. Brainstem, we have cranial nerve involvement or crossed hemiplegia or crossed hemianesthesia. Spinal cord, there is pain and paraparesis. Spinal roots, there is shooting type of pain, weakness and loss of reflexes because roots lead to nerve. So there will be mix of everything, autonomic, sensory as well as motor. Peripheral nerve, there is motor weakness, sensory weakness and autonomic in the particular distribution of the nerve. We have something called stocking and glove in peripheral neuropathy. That also we will discuss. Peripheral polyneuropathy. Neuromuscular junction and muscle will produce only weakness. We will discuss that also subsequently. So this is the gist of what we are going to discuss. So we will discuss many diseases under each of these categories and why it is important to know from an examination point of view or in a basic clinical point of view is we are going to find out what type of disease it from the clues which are given or from the type of scenario which we get. That's why this thing is very important. So the next concept which we are going to discuss is localization in cerebrum. So we are starting from the cerebrum. To know localization in cerebrum, we must know the vascular anatomy. So we have anterior circulation and posterior circulation in the brain. Anterior circulation comes from the internal carotid. So internal carotid divides into the final branch, that is middle cerebral artery. So the middle cerebral artery divides into two branches in the brain. So middle cerebral artery is the very important circulation. Then we have the anterior cerebral artery. The two anterior cerebral arteries connect to each other by the anterior communicating artery. So this is a part of the circle of Willis. Similarly, we have posterior circulation that we will discuss. So the internal carotid artery dividing into the MCA and the anterior cerebral artery which communicate in the front by anterior communicating artery. This forms the anterior part of the circle of Willis. Now, we have four lobes in the cerebrum. So, in front of the central sulcus is the frontal lobe. Behind the central sulcus is the parietal lobe. Behind the calcarine sulcus is the occipital lobe. And below the sylvian fissure is the temporal lobe. So this is the temporal lobe, occipital lobe, parietal lobe. And so we have four lobes. They have very distinct and different functions. Now, middle cerebral artery supplies the entire lateral part here. Okay. Anterior cerebral artery supplies only a strip of the upper part and most of the things go medial. Why this is important is when we have the representation of the limb in the brain, the peripheral limb, especially hand muscle, is represented in the outer part of the brain. So when there is a weakness or when there is an infarct or a problem involving the middle cerebral artery, the hand and the upper limb is involved more. But when there is a problem affecting the anterior cerebral artery, the lower limbs are involved more. That is how the representation in the brain is. So this is one important vascular anatomy which you must understand. So MCA, it supplies major of the lateral part of the brain or outer part of the brain, causes upper limb weakness. Upper limb more than lower limb weakness. But when there is involvement of the anterior cerebral artery, there will be lower limb weakness. When lower limb weakness is there, of course, bladder also will be involved. So this is one applied anatomy from this one. Now, we should know two important areas from this. One is Wernicke's area. Wernicke's area is also called area 44. It is a part of the temporal lobe. Then we have Broca's area. Broca's area is a part of the frontal lobe. This is area 22. So Wernicke's area is area 44, Broca's area is area 22. Wernicke's area is also called it is needed for comprehension of speech or understanding of the speech. Broca's area is needed for fluency. So when middle cerebral artery is involved, we have two branches of the middle cerebral artery, M1 and M2. So M1 supplies the Broca's area, M2 supplies the Wernicke's area. So when one particular branch is involved, the patient may develop either Wernicke's area, Wernicke's aphasia or Broca's aphasia. In Wernicke's aphasia, only comprehension of speech is affected. In Broca's aphasia, only fluency is affected. In global aphasia, both are affected. So here we come to the term aphasia. So don't get very theoretical. Just think of a question or a scenario which is given. Patient comes with sudden onset inability to understand speech. So anything which is sudden onset is a vascular etiology. It could be a hemorrhage or an infarct. Anything which is sudden onset is vascular. Sudden onset inability to speak means there is an involvement of the Broca's area. Right? They are able to understand but they are unable to speak. So that is Broca's area, also called as Broca's aphasia or expressive aphasia. So what artery is involved? A part of the middle cerebral artery is involved. And which lobe is involved? Frontal lobe is involved. Similarly, we have Wernicke's area, Wernicke's aphasia. Wernicke's aphasia, they are able to produce fluency of speech, but they are unable to understand. So since they are unable to understand, they never follow our commands, but they continue to speak irrelevantly. So this is called Wernicke's aphasia. or fluent aphasia. So unable to understand. So it means there is a problem with the M2 branch of the middle cerebral artery, or Wernicke's area or the temporal lobe is affected. Okay. Now what is global aphasia? Both the branches are affected, which means the main middle cerebral artery is affected. This is dangerous because it indicates a large area of the brain is infarcted. Okay. So when you see this diagram, all you have to remember is there is middle cerebral artery which supplies the major of the lateral part of the brain, and it divides into two branches which supplies the Wernicke's area, also called comprehension area, and the Broca's area, which is the fluency area separately. So correspondingly, when there is a lesion, we get aphasia. So Broca's aphasia and Wernicke's aphasia are due to lesions of the middle cerebral artery. Remember, Wernicke's and Broca's area are present only in the dominant hemisphere of the brain. So which is the dominant hemisphere of the brain? Whether the area they are right-handed or left-handed, left hemisphere is mostly the dominant hemisphere. Only 15% of right-handed individuals and around 40% of left-handed individuals have right-sided dominance. So even in left-handed individuals, left hemisphere is the dominant hemisphere. Okay. So this is about the first diagram, the localization of Wernicke's aphasia and Broca's aphasia. Then this is about the anterior cerebral artery, which I was telling you. Anterior cerebral artery mainly supplies the medial part of the brain, and it supplies only a small strip of the outer aspect of the brain. So which part of the body is represented? Medial part of the brain, both the lower limbs. So there will be predominant lower limb weakness when anterior cerebral artery is involved. Now this is even more important, that is the posterior circulation of the brain. So the posterior circulation of the brain starts from the both vertebral arteries, which combine to form the basilar artery. Basilar artery divides into two: posterior cerebral artery. Posterior cerebral artery communicates with the middle cerebral artery through the PCOM, posterior communicating artery. So this completes the circle of Willis. So the two vertebral arteries join to form the basilar artery. The two basilar artery at the end divides into two posterior cerebral artery. Posterior cerebral artery connects with the middle cerebral artery through the posterior communicating artery. Two important structures are present in this area. One is the optic chiasm, what I am shading. One is the optic chiasm, and the second one is this one which I am shading, which is the third nerve or the oculomotor nerve. So this is a very important applied anatomy. The posterior communicating artery is in close contact with the oculomotor nerve. So why this is very important? Because posterior communicating artery aneurysms, they are a common cause of headache. They can compress the oculomotor nerve. So when a question or a scenario is given, like patient is having a chronic headache, they come with sudden increase in headache plus some eye changes, like there is some palsy of the oculomotor nerve plus pupillary changes, then we should suspect that patient already had a posterior communicating artery aneurysm, which has now burst and caused subarachnoid hemorrhage. Right? Now another important anatomical aspect is the pica, posterior inferior cerebellar artery. We have another pica, which is a symptom in iron deficiency, but pica here stands for posterior inferior cerebellar artery, which is a branch of the vertebral artery. What does pica supply? Pica supplies the lateral part of the medulla. We had already discussed about the lateral part of medulla, that is lateral medullary syndrome, also called as Wallenberg syndrome, is one cause of crossed hemianesthesia, right? So what artery involvement leads to Wallenberg syndrome? It is posterior inferior cerebellar artery leads to Wallenberg syndrome. So this is how you must learn neurology. Everything gets connected, right? So instead of learning separately. Once your concepts get cleared, things will become more easier. Right? So you should know about the posterior cerebral artery, the posterior communicating artery, and about the pike artery from this diagram. So this supplies the entire posterior circulation. Okay. So this is what we were discussing some time back. That is, you must know about the cross section of the brainstem at different levels. Why you must know the cross section of brainstem at different levels? Because we must, only when we know which structures are present there, we can understand the different types of syndromes. So this is about medulla. Okay. So medulla, I was telling you, the lower part of the medulla, crossing of the corticospinal tract occurs. That is called as pyramid. So this, the shaded area is the pyramid here. And I told you one mnemonic. The medial part of the brainstem always have the motor fibers. So many M's are present. See, medial lemniscus. Medial lemniscus contain the posterior, the dorsal column. The dorsal sensory column fibers are present in the medial lemniscus. So it carries sensations about proprioception, vibration, etc. So 1M, which is medial, is medial lemniscus. So when medial part of the medulla is involved, what will happen? There will be loss of proprioception and vibration. The next M is medial longitudinal fasciculus, MLF. Medial longitudinal fasciculus is a structure which comes in gaze control. Okay, there is a mnemonic called CPM. Cortex, pontine, paramedian reticular fasciculus and medial longitudinal fasciculus. If we have time, we will discuss that. So MLF has one important role in eye movement. The function of MLF is it supplies the abducen nerve. So median longitudinal fasciculus supplies the abducen nerve. So MLF is one medial structure. So when this is gone, there will be some problems in the eye movement. Then there is one motor cranial nerve which is involved, that is hypoglossal nerve. The 12th nerve nucleus is medial. So the motor cranial nerve. Then obviously pyramid is also medial, right? So the motor cortex or motor fibers. So these structures are medial. So when there is a medial medullary syndrome, many of these are prone to get affected. So MLF can be affected, medial lemniscus can be affected, pyramid can be affected, and the hypoglossal nerve can be affected. Now see the lateral structures here. So lateral has many connections with the cerebellar tract, right? Cerebellum has an important function in balance. Problem with the cerebellum usually leads to ataxia. Fifth nerve nucleus is lateral because fifth nerve is mostly sensory. Ninth and 10th nerve nucleus is lateral because they are also mainly sensory nerves. So 9th nerve nucleus, 10th nerve nucleus, 5th nerve nucleus. Now don't get confused why 5th nerve nucleus is coming in the medulla. One nucleus of the 5th nerve comes from the midbrain up to the medulla. It's a very long nucleus. So part of the 5th nerve nucleus also comes in the medulla. So 9th nerve and 10th nerve also comes here. Nucleus tractus solitarius, you would have heard. It's the one of the nucleus of the vagus nerve. So many 9th and 10th nerve and 5th nerve nucleus only come lateral. So in lateral medullary syndrome, these things will be affected. So what are the other things we just discussed? The spinothalamic fibers are lateral. So there will be hemianesthesia, crossed hemianesthesia. Then there will be ipsilateral loss of 9th and 10th nerve function. That is also self-understood. And remember, 5th nerve nucleus is also involved in the lateral medullary syndrome. So there will be loss of sensation of the ipsilateral side of face. Okay. So this is how you differentiate between medial medullary syndrome and lateral medullary syndrome. Now I just portrayed a picture here because nowadays video questions or image questions are also asked. So this is at the level of the medulla. How do you say that it's at the level of the medulla? by, it is the lowest mode part of the cranium, right? Nose is there. So in front of the cerebellum, close to the nasal cavity only, we have the medullary structures. Now this is a section one step above. The same rule holds here also. The medial structures are usually motor. See, medial lemniscus is medial. And what are the motor structures? The sixth nerve nucleus is bit medial. But what all is lateral? The seventh nerve is also medial. So sixth nerve, seventh nerve, medial lemniscus, all these are medial. What are lateral? Eighth nerve, some of these are lateral. So just understand that basic concept, only then we can help to know the differences. That is lower pons, this is mid pons. So the cerebellar connection, where it comes. See, when it comes in the superior pons, things are very much clear, right? Medial lemniscus is medial. The corticospinal tract is medial. See, what all is lateral? Spinothalamic tract is lateral. Spinothalamic tract only forms the lateral lemniscus, that is lateral. Cerebellar connection is lateral, right? So at least remember everything by this diagram. Medial has the medial longitudinal fasciculus, motor fibers, and medial lemniscus. Lateral lemniscus, spinothalamic tract, superior cerebellar peduncle, everything comes laterally. This is midbrain. Midbrain, there are two nucleus only. One is third nerve nucleus and another one is fourth nerve nucleus. We have something called as red nucleus, which helps in movement, the problem of which can cause tremors. Okay. And there is something called as periaqueductal gray matter, because aqueduct of Sylvius comes in this region. We have superior colliculus here. There is another section in the midbrain which is inferior colliculus. So whatever you had learned in your anatomy, just try to recap it here. But the main thing which you must remember even when you forget everything is the medial longitudinal fasciculus, medial lemniscus, motor fibers, everything comes medially. All the sensory fibers, cerebellar connections come laterally. Only if you know that, you can remember the syndromes. Now, see here, Weber syndrome. We had discussed Weber syndrome. It is a midbrain syndrome. Okay, it is a midbrain syndrome. So what structures are involved in Weber syndrome is third nerve and corticospinal tract. So there is ipsilateral cranial nerve palsy and contralateral hemiparesis. This is the simplest form of crossed hemiplegia. Benedict syndrome, also the same concept, but what structures are involved here is third nerve nucleus, red nucleus, and corticospinal tract. So I told you red nucleus has something to deal with ataxia and tremors. So when Benedict syndrome is there, there will be ipsilateral cranial nerve palsy, right? There will be contralateral hemiparesis, right? Plus in addition there will be ataxia and tremors. Why there is ataxia and tremor? Because of red nucleus involvement. We have Claude syndrome. Claude syndrome is only involvement of third nerve and red nucleus. So there will be ipsilateral cranial nerve palsy and contralateral ataxia. So basically Weber syndrome is hemiparesis, Claude syndrome is tremors, Benedict syndrome is a mixture of Weber syndrome and Benedict syndrome. Parinard syndrome is dorsal midbrain syndrome. You may get confused here. Dorsal midbrain has an important function with upgaze and downgaze. Okay, dorsal midbrain has an important function with upgaze and downgaze. So when there is problems here, there will be problems with upgaze. There will be some conversion retraction nystagmus. Such things occur. They say it by the mnemonic clues: conversion retraction nystagmus, light near dissociation, upgaze palsy. Okay. So at least remember these three important syndromes. Weber's is crossed hemiparesis, Claude's is crossed tremors, Benedict's is hemiparesis plus tremors. Now what about Millard-Gubler syndrome? Millard-Gubler syndrome is a pontine syndrome. So what is there in the pons? Seventh nerve nucleus is there, corticospinal tract is there. So there is ipsilateral, facial nerve palsy, and contralateral hemiparesis. So simple. What is Foveli syndrome? Remember, the sixth nerve is also there in the pons. So, seventh nerve palsy, gaze center palsy, and corticospinal tract. So, Millard-Gubler and Foveli syndrome are basically the same. There is ipsilateral facial nerve palsy and contralateral hemiplegia, but Foveli syndrome in extra has horizontal gaze palsy. So, this was asked in some exams. When one NEET PG, this was asked. Right? So, remember 3 midbrain syndromes: Weber syndrome, Claude syndrome, Benedict syndrome. 2 midbrain pontine syndromes. Millard-Gubler syndrome is involvement of pons, seventh nerve with contralateral hemiplegia. Foveli syndrome is seventh nerve palsy, contralateral hemiplegia, and gaze palsy. Now coming to Wallenberg syndrome. This we have discussed multiple times. It involves a lateral medulla. So what are the structures involved here? Fifth cranial nerve we had discussed, because fifth nerve nucleus comes down up to the medulla. Fibers of the ninth and 10th nerve, yes, they are lateral. Sympathetic fibers also come here. So that's why Horner syndrome comes. Vestibular nucleus is lateral, right? That also I had shown in the image. From the pons and medulla, vestibular fibers are lateral. Cerebellar connection is lateral, right? But what doesn't come here? Motor tract does not come here. Okay. The spinothalamic tract also will be the lateral. So what are the structures will be there? There will be ipsilateral facial loss, ipsilateral facial sensory loss because of fifth nerve involvement. There will be contralateral hemianesthesia of the body because of the spinothalamic fibers. That is lateral lemniscus involvement. There will be ipsilateral Horner syndrome, loss of corneal reflex because of sympathetic. Then there will be weakness of the palate, loss of gag reflex, and paralysis of the vocal cord because of 9th and 10th nerve involvement. Okay, 9th and 10th nerve come bit lateral because they are mixed motor and sensory. Then there is cerebellar ataxia on the ipsilateral side, right? So ipsilateral cerebellar symptoms: ipsilateral facial loss, ipsilateral palatal palsy, ipsilateral Horner syndrome, and contralateral body sensory loss is lateral medullary syndrome caused by posterior inferior cerebellar artery, which is a branch of the vertebral artery. Okay. Now we have another syndrome called as Digerin syndrome or medial medullary syndrome. So what is there in the medial medulla? All the M's. So the motor cranial nerve, which is the 12th nerve, the medullary pyramid. So this is also simple. That is ipsilateral 12th nerve palsy causing ipsilateral tongue weakness and contralateral hemiparesis. So even if you don't remember other syndromes, remember Weber syndrome, Claude syndrome, Benedict syndrome, if possible Parinot syndrome in the midbrain, Millard-Gubler and Foveli syndrome in the pons. The difference between Millard-Gubler and Foveli is lateral gaze center is also involved in Foveli syndrome. Wallenberg syndrome, never forget, it is crossed hemianesthesia. Medial medullary syndrome or Digerin syndrome is again very simple, tongue palsy and contralateral hemiparesis. So we have discussed some localization in the cerebellum and localization in the brainstem. Now that the tougher structures are over, because till now we had to deal with much of anatomy, we had to deal with the blood supply. So this is the toughest part. We have to integrate anatomy, radiology, etc. From this will be pure medicine. So the disease which we are going to now discuss is cerebrovascular accident. Cerebrovascular accident is anything, how does it present? Any disease which is sudden. So patient who is normal comes with sudden weakness. Patient who is normal comes with sudden giddiness. Patient who is normal comes with sudden loss of consciousness. Think of CVA. So CVA can be ischemic or hemorrhagic. 85% of the cases are ischemic stroke, 15% of the cases are hemorrhagic stroke. Ischemic stroke can be two things. It could be thrombotic or embolic. See, atrial fibrillation is a reason for embolic stroke. So where does the embolus come from here? So there may be atrial fibrillation. Atrial fibrillation is one risk factor for clot formation in the left atrium or left atrial appendage. So when the rhythm gets normalized, it can go. So how will you treat this one? The main stay here is anticoagulation. It is not antithrombotics, that is antiplatelet, it is anticoagulation. So anticoagulation, we know it could be no oral anticoagulation or warfarin. When given as injection, it is the heparin or low molecular weight heparin or fondaparinux. So carotid disease. So this is a reason for thrombotic. So how will you treat it finally? We have to give antiplatelets, and suppose if carotid is very much stenotic, we have to give a stenting. So this is the major cause, embolic or thrombotic CVA. Now what about hemorrhagic stroke? The main risk for hemorrhagic stroke is hypertension. So hypertension causes bleeding in mainly 3 areas of the brain. One, it can bleed in the pons, it can bleed in the cerebellum, it can bleed in the basal ganglia, right? Basal ganglia or the thalamic region. Why this is important is, I'll show you some series of CTs a little bit later. Because hemorrhagic CV usually involves these regions due to hypertension. But other causes like trauma will involve other places. When you think of hemorrhage, we should not only think of cerebral bleed, we can also think of subarachnoid hemorrhage. There are 3 causes of subarachnoid hemorrhage. One is traumatic. Any trauma can cause bleeding in the subarachnoid space. Second, bleeding from an aneurysm. I told you posterior communicating aneurysm are common. PCOM aneurysm is in close contact with the third nerve, like a patient who is having a chronic headache who suddenly presents with a sudden very worst headache in his life. A patient with chronic headache suddenly presents with a very worst headache, then you should think of an aneurysm going in for a subarachnoid hemorrhage. The third reason for subarachnoid hemorrhage is these are the 2 important causes of subarachnoid hemorrhage. Even hypertension can cause, at least remember these 2. So SAH also should be ruled out, hypertensive ICH, and there are other causes. Because if there's an aneurysm, then we have clipping and coiling are the options. If it is trauma, treat the cause. If it is hypertension, reduce hypertension plus supportive management. What is TIA? Transient ischemic attack. It is like a precursor for ischemic stroke. It's a precursor for ischemic stroke. So the definition is said is any focal neurological deficit which lasts less than 24 hours. Okay. Remember, in ischemic stroke, like in for MI, we have a window period. So the window period is 4.5 hours. Textbooks may say it is up to 6 hours. So within 4.5 hours, if the patient presents to the emergency, and if it is an ischemic stroke, then we can do a procedure called as thrombolysis. In myocardial infarction thrombolysis, we had many drugs. We had streptokinase, we had altiplase, we had retiplase, and we had tenecteplase. But in stroke thrombolysis, we have only one drug which can be used, that is altiplase. And nowadays in some centers they are using tenecteplase. So only these 2 can be used. Why these 2 are used? Because they are very specific and the chance of bleeding in other organs is less. So if one answer, then just say altiplase for now. But some centers have started using tenecteplase now. 4.5 to 6 hours also we can do thrombolysis, but that is an intra-arterial thrombolysis. But beyond 6 hours, there is no role for thrombolysis. So the statement is said plainly. Of course, there are some situations where we can do thrombolysis even in ischemic stroke beyond 6 hours but less than 24 hours. But that is by doing some MRI and identifying some few specific findings, right? So if some tough question has to be asked, of course, thrombolysis can be done between 6 hours to 12 hours or even up to 24 hours. provided MRI is showing viable tissue, right? I'm not telling the technical terms to avoid confusion. But beyond 24 hours in stroke, is there a treatment actually? Yes, there is a treatment, that is thrombectomy. So it is a surgical option. So till now, up to 6 hours, we are discussing thrombolysis, which is a medical treatment. More than 24 hours, still we have an option, that is thrombectomy. It's a mechanical thrombectomy. It is a surgical removal of the clot. So this is the treatment protocol for ischemic stroke. TA is actually the same stroke which resolves within 24 hours completely. There is a scoring for that. You need not remember that. I just put it here to tell that there is a definition called transient ischemic attack. Transient ischemic attack means that patient may develop an ischemic stroke in future. So we started about the anatomy of the brain. We are discussing about middle cerebral artery strokes. We are discussing about anterior cerebral artery strokes. We are discussing about posterior cerebral artery strokes. We are discussing about the brainstem syndromes, right? And we are telling about how to classify the causes and how to treat it. Where to give oral anticoagulation, where to give heparin, where to give antiplatelets, and what is the definitive treatment. Now, there are some, we'll come to cranial nerves. So brainstems and cranial nerves. Remember, cranial nerves originate from the nucleus in the midbrain or pons and medulla, and they go through some holes. In anatomy, they would have discussed. For example, in orbital apex, the second nerve, third nerve, fourth nerve, the first division of fifth nerve, that is ophthalmic nerve, sixth nerve, everything comes through the orbital apex. So if some disease like fungal infection or tumor comes in the orbital apex, all these can be involved. Right? In sphenoid fissure, it is third nerve, fourth nerve, the first division of fifth nerve and sixth nerve. Lateral wall of cavernous sinus is also the same thing, plus there is proptosis. So orbital apex syndrome, superior orbital syndrome, and lateral cavernous sinus syndrome, everything presents with the same. The second nerve, the third nerve, fourth nerve, the sixth nerve, and the ophthalmic nerve. All these four are involved. In orbital apex, in addition, the second nerve is involved. In lateral wall of cavernous sinus, in addition to 3, 4, 5 and 6, there is proptosis, pulsatile proptosis. Most of the conditions will be infections or tumors. Right? Think of petrous apex bone, because petrous apex bone has 5th nerve and 6th nerve. Think of internal auditory meatus, because 7th nerve and 8th nerve are only present in internal auditory meatus. Think of the jugular foramen, 9th, 10th and 11th nerve. So this is again just a revision of the anatomy. Think of the fissures, think of the nerves which go. So if they are giving you features suggestive of particular cranial nerve palsies, you can try to fix from what hole the cranial nerve is coming and what fissure is commonly involved. Yes. So now this is about combined or multiple cranial nerve palsies. Now we can discuss about 3 important cranial nerves. 3 important cranial nerve diseases. One is trigeminal neuralgia. It's a disease of the trigeminal nerve. Next is Bell's palsy. It is a disease of the 7th nerve. Then we have the pecam aneurysm, or some discussion about the 3rd nerve. So we'll finish off 3rd nerve first, because we had just discussed it in short. So this is the diagrammatic representation. So if this is the pituitary, the important structure, the optic chiasm, is in front of the pituitary, and surrounding the pituitary only the circle of Willis is there. So see here, this is the revision of the circle of Willis. The internal carotid artery divides into the medial cerebral artery and the anterior cerebral artery. The 2 anterior cerebral artery combine to form the anterior communicating artery. From posteriorly, the 2 vertebral arteries join to form the basilar artery. Basilar artery divides into the 2 posterior cerebral artery. The pecam connects the posterior cerebral artery with the middle cerebral artery. So this completes the circle of Willis. The posterior communicating artery is in close contact with the trigeminal nerve. The oculomotor nerve. So since the third nerve is in close contact with the posterior communicating artery, when there is a posterior communicating artery aneurysm, it can compress the outer part of the third nerve. Now, what are the muscles which are supplied by the third nerve? We had remember the mnemonic SO4 LR6. That is, there are 6 eye muscles, right? The medial rectus, lateral rectus, superior rectus, inferior rectus, inferior oblique, superior oblique. The 6 eyeball muscles. Medial rectus causes adduction. Lateral rectus causes abduction. Superior rectus causes elevation. Inferior rectus causes depression. This is very simple. Inferior oblique causes extorsion, that is rotation of the eye. Superior oblique causes intorsion. Okay, so medial rectus causes adduction because it is medial. Lateral rectus causes abduction because it is lateral. Superior rectus causes elevation because it is superior. Inferior rectus causes depression because it is inferior. Inferior oblique causes extorsion because it pulls the eye inwards. Superior oblique causes intorsion because of the position of the muscle. Now, what nerves are supplied by this? SO4, that is superior oblique, is supplied by the 4th nerve or trochlear nerve. LR6, lateral rectus, is supplied by the 7th nerve or the abducens nerve, the whole power 3. All the remaining others are supplied by the oculomotor nerve. So the medial rectus, I'll do a different color. The medial rectus, the superior rectus, the inferior rectus, inferior oblique, all these are supplied by the 3rd nerve. Plus we have levator palpebrae superioris, the eyelid muscle, that is also supplied by the 3rd nerve. So when there is 3rd nerve palsy, what all will be affected? 1. Levator palpebrae superioris is affected, so there can be ptosis. Second, medial rectus is affected, so the eye cannot move medially. So what will happen? Since the lateral rectus is functioning normally, the eye will be pulled laterally. So eye will be squinted out. So our eye is abducted. Eye cannot be abducted, so eye is abducted. Eye will be out. Now what else will function? The inferior oblique is not functioning, by superior oblique is functioning. So eye will be rotated. So the eye will be intorted. So eye is abducted and intorted. Okay. So this is how the eye will be. So eye will be ptosis and it will be moving, it will be abducted, at least you can remember that. Now what will happen to the pupils? Because if you remember, pupillary constriction is a function of the parasympathetic system. Pupillary dilation is a function of the sympathetic system. Okay, pupillary constriction is a function of the parasympathetic system. Pupillary dilation is a function of the sympathetic system. Oculomotor nerve carries parasympathetic fibers. So that pupillary fibers are lateral in the oculomotor nerve. The pupillomotor fibers are situated laterally in the 3rd nerve. So since it is situated laterally, we just show the diagram. When an aneurysm comes in the posterior communicating artery, it can easily compress the 3rd nerve from outside. So any compressing lesion like PCOM aneurysm, will affect the pupillary constriction also. So when pupil is not constricted, what will happen? Pupil will go for dilation. So if you examine the eye in a person who has a chronic headache, who comes with a sudden severe headache of lifetime, you can see that his eye will be abducted, he will have ptosis, and his pupil will be dilated. When there is oculomotor nerve palsy with pupillary dilatation, it is a surgical condition, PCOM has ruptured. But at the same time, there is another condition which causes third nerve palsy, which is diabetic third nerve palsy. Diabetic third nerve palsy. In diabetic third nerve palsy, since vasculature is the problem here, the innermost fibers are affected, which means pupillary fibers are spared. Pupillary fibers are spared in diabetic third nerve palsy. So here how will be the picture? Again there will be ptosis, there will be abduction of the eye, but if you see the pupillary reaction will be intact. So if you remember the third nerve or the oculomotor system, at least remember the muscles which are supplied by it and the difference between surgical lesions, surgical third nerve palsy and a medical third nerve palsy. So this completes short discussion about the third nerve. There are still lots to discuss here. We are not discussing that to avoid any confusion. And we will discuss Bell's palsy. Bell's palsy is a type of seventh nerve palsy. Seventh nerve palsy is of two types: UMN type of seventh nerve palsy and LMN type of seventh nerve palsy. What is UMN? If you see the facial representation, this is a facial representation. You can divide the face into upper half of the face and lower half of the face. So the upper motor neuron facial fibers supplies the entire side of the face, plus it also supplies the opposite side, upper side of the face. So this side human facial fibers also supply the entire side of the face, plus it also supplies the opposite half of the face, which means when there is a UMN type of palsy, only the lower half of face will be affected because there is the upper half of the face is also supplied by the other side. So the thing to remember here is UMN palsy will involve only lower half of the face. It will involve only lower half of the face of the same side. Now what happens in LMN palsy? LMN palsy is simple because LMN fibers supply only the same side. So if there is an LMN palsy, the entire side of the face is affected. Okay, so when there is a facial nerve palsy, our difference is to find out whether it is UMN palsy or LMN palsy. What is UMN? The fiber starting from the cortex and ending in the third nerve nucleus, till that is called upper motor neuron fibers. The fibers beginning from the seventh nerve nucleus in the pons and going up to the face are called lower motor neuron fibers. So this is how you differentiate between UMN palsy and LMN palsy. Bell's palsy is a LMN type of palsy. Bell's palsy is an LMN type of facial palsy. If it is LMN type of facial palsy, what does it mean? Which part of the nerve is affected? The part from the cranial nerve nucleus, seventh nerve nucleus in the pons till up to the end organ, till up to its branching in the parotid. So actually it involves the part of the cranial nerve, part of the seventh nerve which travels through the ear. So it is an LMN palsy, at least remember that. So when it is LMN palsy, the entire face will be affected. We know very well that facial nerve supplies the muscles of facial expression. So their forehead will not shrink, their eye will not close, there will be deviation of angle of mouth to the opposite side. Okay. If you get confused about deviation, remember the 12 plus 5 equal to 10 plus 11 rule. 12 plus 5 or 10 plus 7 is equal to 17. 12 is 12th nerve, 5 is 5th nerve. When there is a palsy of the 12th nerve or 5th nerve, there is ipsilateral deviation. Which means if there is a 12th nerve palsy, the tongue will be deviated to the same side. If there is a right side 12th nerve palsy, the tongue will be deviated to the right side. If there is a 5th nerve palsy, what does 5th nerve supply? The muscles of mastication. If there is an ipsilateral 5th nerve palsy, the entire jaw will be deviated to the same side. Right? So 12 plus 5 equal to 17. 12 and 5 is ipsilateral deviation. Similarly, 10 plus 7 is equal to 17. 10 is the 10th nerve. 10th nerve supplies the vocal cord or the palate. Okay. So when there is palsy of the 10th nerve, the uvula will be deviated to the opposite side. So if there is a right side 10th nerve palsy, uvula will be deviated to the left side. So what happens to the 7th nerve? If there is a right side facial nerve palsy, there will be the angle of mouth will be deviated to the left side. Right? So there will be contralateral deviation of the angle of mouth. So in 12th nerve or 5th nerve lesion, there will be deviation of angle of mouth to the side. There will be deviation of the tongue or deviation of the jaw to the same side. In 10th or 7th nerve palsy, there will be deviation of uvula or deviation of angle of mouth to the opposite side. So why again this is very important? To easily crack questions or to easily crack scenarios without getting confused. Right? So LMN is a lower motor neuron type of facial palsy. Ipsilateral entire face is affected. There will be deviation of angle of mouth to the opposite side. So usually it is post-viral. Treatment is steroids. Okay, one treatment is steroids, prednisolone. So this completes the second disorder of the cranial nerve, the 7th nerve. Now coming to trigeminal neuralgia. So trigeminal neuralgia is a problem with the trigeminal nerve. I told you, trigeminal nerve supplies muscles of mastication. Also it supplies the entire sensation of the face. Assume that there is a vascular lesion or a vascular loop which is compressing the trigeminal nerve. So when there is compression of the trigeminal nerve, there will be severe pain in one side of the face. That pain will be aggravated on chewing, on movements, on exposure to cold air, right? So diagnosis, when doing a MRI brain, we can get that vascular loop. Okay. Now since we spoke about MRI, I'll just tell about the imaging protocols in the brain. So we have functional imaging and structural imaging. Functional imaging is EEG, which we'll discuss shortly in another section. The structural imaging of the brain is mainly CT brain or MRI brain. We know very clearly that MRI is very clearer than CT. But why does CT score better than MRI? Because it is time saving in an emergency. MRI, it is time consuming. Now assume the scenario of ischemic stroke, CVI, which we had. So there is a sudden onset weakness of one side. We are suspecting a cerebrovascular accident. We have to differentiate whether it is ischemic stroke or a hemorrhagic stroke. Which is the best investigation? MRI brain. Because MRI brain, a CT brain cannot pick up early lesions. It will take minimum 6 hours for changes in CT to appear. Early changes of ischemia cannot be picked up in a CT brain, but it can be picked up in an MRI brain. So the best test to diagnose ischemic stroke is MRI brain. But in scenarios when they ask what is the next best step, MRI brain is not the option, because if a patient comes at the 3rd hour of weakness, they are still in the window period. We do not want to waste time. We just want to prove that there is no hemorrhage, because presence of hemorrhage is a contraindication for thrombolysis. If there is no hemorrhage, obviously it's an indication for thrombolysis. So CT brain is the best next step. In the case of CVA, the next best step will be CT brain to rule out hemorrhage. But MRI brain will be done later, because to correctly quantify the amount of ischemia. But suppose they had crossed the 6 hours time interval or the 24 hours time interval, MRI can be done directly because there is no point in doing CT brain at that time, right? Similarly, for seizures, MRI brain will be better than CT brain. MRI picks up other lesions. So we'll discuss it sometime later. Okay, just remember the role of imaging in CT, imaging in CVA. So this completes the cerebrum, brainstem, and the cranial nerve lesions, the important concepts. Of course, neurology cannot be covered very easily. I don't want to explain every single small concept. I'm just refreshing what is important to help you to read your notes which are already taken. Now we'll proceed with the next concept. So we are discussing cerebral lesions produce hemiparesis, coma, and one thing is seizures. So seizure is an abnormal electrical activity in the brain that we know very well. So how will you classify seizure is either it's a generalized onset seizure or a focal onset seizure. Focal onset seizure is classified into focal onset seizure with intact awareness and focal onset seizure with impaired awareness. So what does it mean? So previously it was called as simple partial seizure and complex partial seizure. Focal seizure means there is some lesion in some part of the brain. It is producing, assume that there is some lesion in the temporal lobe of the brain. So since there is a lesion, it will produce an abnormal electrical discharge. So it will produce many symptoms which are related to the temporal lobe. Remember, temporal lobe has a role in hearing, temporal lobe has a role in memory, it has a role in behavior. So when there is an abnormal discharge from the temporal lobe, they can develop some behavioral disturbances. Likewise in the frontal lobe, they can develop some behavioral disturbances there. So that is focal seizures with intact awareness and focal seizures with impaired awareness. Generalized onset seizure is, even though it starts from one part, it involves the entire body equally. So it is of tonic seizures, clonic seizures, or generalized tonic-clonic seizures. GTCS is the common one we commonly witness. So how does it start? It usually starts with loss of consciousness, uprolling of eyeballs, falls. So even though it starts from one side, it rapidly goes to every place, and vocal cord will be palsied, so they'll produce some abnormal sound, and their entire body will be tonic. So we would have witnessed GTCS definitely. There is something called as absent seizure. There will be no tonic-clonic movement, but they'll suddenly stop. They'll be speaking, they'll suddenly stop. Right? They'll be doing some activity, they'll suddenly stop. Don't confuse absent seizures with atonic seizure. Atonic seizure is they'll be doing something, they'll lose their tone and suddenly fall. So GTCS is a seizure with heavy abnormal movements. Absent seizure is they'll be doing something normally, they'll suddenly stop. Atonic seizure is they'll be doing something, they'll suddenly fall. Myoclonus is a jerky movement. So it's a seizure with a jerky type of movement. So if time permits, keeping this in mind, you can see one video for each type of seizure, because since video type questions are coming more from neurology, definitely many image based questions or many video based questions may be asked. Right. So this is about classification of seizures. Now EEG is the functional imaging of the brain. CT or MRI is the structural imaging of the brain. EEG is the functional imaging of the brain. Interpreting or understanding that is very simple, right? Like an ECG, they have taken only a recording. See, what does this lead mean? F is frontal, P is parietal, T is temporal, O is occipital. So FP1 to F7 means they have kept the leads in two places. They'll map the brain and they'll divide it into multiple electrodes and they'll fix it. So T6 and O2 is the electrode is between temporal lobe and occipital lobe. That's all is enough to understand. See the difference between image 1 and image 2. In image 1, the entire sequence of the ECG is showing some abnormality from this point, right? See, this is normal. Here there is some abnormal electrical activity. It is in every place, in frontal region, occipital, parietal, temporal, everywhere there is an abnormality. So this looks like a generalized seizure, right? But see here the seizure activity is coming only in a particular lobe, frontal and temporal. So this is definitely a focal seizure. So when you are given an ECG, just try to see whether it is generalized or focal. See, here again it is generalized, but this is following a specific pattern, right? There is a spike and a wave, spike, wave, spike, wave. The spike wave pattern is very typical for absence seizure. So the first one which you see is actually generalized tonic-clonic seizure. This one is definitely a focal seizure. Since T is there, it is coming from the temporal lobe. Temporal lobe usually causes impaired awareness. Okay, so this is actually focal seizure with impaired awareness because temporal lobe is involved. This is again a generalized seizure, but we are seeing a spike wave pattern. In pediatrics, maybe you would have heard the burst suppression pattern. Comes in hypoxic encephalopathy. Okay, so that completes EEG. Now, how does imaging help in seizures? So, what is seizure? What is epilepsy first? Seizure is a syndrome. Seizure is a clinical manifestation due to abnormal electrical activity in the brain. When there is repeated seizures, we call it as an epilepsy without any reason. When there is a repeated seizure without any reason, we call it as an epilepsy. Like for example, a person who has been given some injection like a tramadol injection suddenly develops one episode of fits. We can call it seizure because there is some provoking factor, he has developed a seizure. A person with hypoglycemia, he comes in seizure, and that's actually a seizure, symptomatic seizure. But a person who develops 3 to 4 episodes of seizure, or he develops one seizure episode in every month without any of this reason, we can call it as an epilepsy, or there's an epilepsy syndrome. So recurrent seizures which are unprovoked can be labeled as an epilepsy. Or if there is an epilepsy associated with a syndrome, we call seizure associated with a syndrome, we call it as an epilepsy. Right? For example, we have some West syndrome, Dravet syndrome, Lennox-Gastaut syndrome. The MRI brain shown here is also one syndrome. So this part of the brain is called hippocampus. There is hippocampal atrophy. So this is called medial temporal lobe epilepsy. Hippocampus is a part of the medial temporal lobe. So medial temporal lobe is atrophic. So this is one syndrome, right? So if a scenario is asked, patient develops seizure for the first time, what you will do immediately is you should always check for any reversible factors, right? Only if a particular seizure is provoked, it is enough to correct that provoking factor. You need not give these drugs. But only if you label them as epilepsy, that is, if they are having a syndrome or they have repeated seizures without any provoking factor, only then we can call it as an epilepsy and we are supposed to give anti-epileptic drugs. Okay. EEG can be normal in epilepsy. You need not have a normal EEG because you are doing the EEG at the time when the patient is normal. Most of the time EEG may be normal. A normal EEG does not rule out epilepsy. Now, how does imaging help? I told you MRI brain is very useful in focal seizures to find out what lesion is causing the focal seizure. Maybe it could be an infection, it could be an abscess, it could be a tumor or a calcification or a neurofibromatosis, whatever it may be, or a tuberculoma. So what you have to remember is there are multiple anti-epileptic drugs. We are not going to discuss that fully here. I'll just tell you the drug of choice. According to Harrison, GTCS, lamotrigine and valproic acid are the first line drugs, sodium valproate. If it is a focal seizure, lamotrigine carbamazepine, oxcarbamazepine, phenytoin, and levetiracetam. Carbamazepine and oxcarbamazepine, few side effects are worthy to be mentioned. One, hyponatremia. Hyponatremia is more common with carbamazepine, less common with oxcarbamazepine. Another thing is, in people with few cytochrome mutations, in a few HLA mutations, like HLA-B5102, I guess, please note it down. So in particular HLA mutations, they can go for Steven-Johnson syndrome. Okay, so usually they say we have to check for this HLA mutation before giving the drug. Now, absent seizure, valproic acid and ethosuximide are the first choice. So GTCS, first is lamotrigine as per Harrison, focal lamotrigine, carbamazepine, oxcarbamazepine, absent seizure, valproic acid, ethosuximide. We have atypical absent seizure also, where valproic acid, lamotrigine and topiramate. Just remember at least one name. Valproic acid comes in absent seizures, focal seizure, carbamazepine, oxcarbamazepine. Again, GTCS, valproic acid is still used. Valproic acid doesn't come in focal seizure, please remember that. Now, what is status epilepticus? When seizure lasts more than 5 minutes, it is status epilepticus. When that seizure is lasting more than 5 minutes, is a GTCS, we call it as generalized convulsive status epilepticus. Because generalized tonic-clonic seizure is going for status epilepticus, so we call it as GCSE. If it is a focal seizure which is continuing, it's a focal seizure which is causing GTCS, we call it as epilepsia partialis continua. Epilepsia partialis continua. Partial epilepsy which is continuing. Because partial seizure was the old term for focal seizures. Suppose if it is an absent seizure which is going for status. Remember, absent seizure can also go for status epilepticus. It is difficult to find out because patient will be comatose. I told you, absent seizure, patients will be normal, they stop suddenly. So a normal person who suddenly becomes unconscious for more than 5 minutes, especially in ICU, one of the DD could be absent seizure. So that's why EEG is very important in them. So that is called as non-convulsive status epilepticus. So the three types of status epilepticus are generalized convulsive status epilepticus, non-convulsive status epilepticus, and epilepsia partialis continua. Even if you don't remember the left side, based on the time duration, they are given a name. Like more than 5 minutes to 30 minutes, we call it as impending status epilepticus. 30 minutes to 2 hours, it's called as established early refractory status epilepticus. More than 48 hours is late refractory. More than 7 days is super refractory. But understand this sequence. Less than 30 minutes or the first time when they come in contact, we are supposed to give IV benzodiazepines, lorazepam, midazolam or clonazepam. Next step, we are supposed to give phenytoin, sodium valproate or levetiracetam in heavy doses. So these are the first two steps. Give benzodiazepine, give phenytoin or levetiracetam, and next you have to classify whether it is generalized convulsive epilepticus or non-convulsive status epilepticus. Because if it is generalized convulsive, give benzodiazepine infusion. If it is non-convulsive status epilepticus, we can give another dose of drugs like levetiracetam, phenytoin or sodium valproate. The next after this will be barbiturate infusion, barbiturate coma. Still barbiturate coma fails to control. The last one will be we have to knock out the person by giving general anesthetic. Remember, there are some special drugs like ketogenic diet. It is used in some seizure types. Okay. But understand this sequence. IV benzodiazepines, IV anti-epileptic drugs, benzodiazepine infusion, phenobarbital coma, and last one will be general anesthetic. So this finishes a short discussion about seizures. So how to identify seizures, what investigation to plan, what drug to give, right? Now coming about headache. Headache is also a pathology associated with the cerebral cortex. So headache is classified into secondary headache and primary headache. Secondary headache and primary headache. Secondary headache is some disease which is causing secondary headache. For example, any brain infection like CNS infection can cause headache. Any bleeding like subarachnoid hemorrhage can cause headache. Primary headache, they do not have any brain disease, but they are going for headache. So there are some primary headache syndromes like migraine. We have cluster headache. I'll write here as cluster headache and related diseases, because there are some 4 diseases related to cluster headache. And we have TTH, which is tension type of headache. Actually, the most common is tension type of headache. Tension type of headache will be a band-like headache, usually frontal. Okay, so it's very common. It's a dull aching type. Now, migraine is commonly noticed or commonly discussed. So there is a criteria for headache. So remember the criteria is 5, 4, 3, 2, 1. There are 5 distinct episodes. So repeated episodes is there is 5 distinct episodes, each lasting 4 hours to 72 hours. 72 hours is 3 days. So 5 episodes which last 4 hours to 3 days. This timing is important because if headache is less than 4 hours, it is not migraine. Please remember that. If headache is lasting more than 3 days, it is also not migraine. Plus, there should be 2 of the following features: unilateral throbbing pain aggravated by movement. This is very important. Aggravated by movement, because in cluster headache, the headache is relieved by movement. So patients with migraine, they never move. They sit quietly to get relief of the pain. Whereas patients with cluster headache will be very restless. They'll be moving about. And it will be moderate to severe intensity. Plus 1 of the following, either nausea or vomiting, and photophobia or phonophobia. So 5 episodes lasting 4 hours to 3 days with 2 of the following: 2 of unilateral throbbing aggravated by movement, moderate to severe intensity, and 1 of photophobia or phonophobia and nausea and vomiting. So migraine treatment can be classified into treatment and prophylaxis. There is a score called Maida's score. Like if you put this score and say that migraine is severe, when you say migraine is severe, it is self-explanatory. Like the person has to quit his job because of his headache. He takes leave often due to his headache. It is impairing his social life, then it is called as severe. In that case, we should not only give treatment during attacks, we should also give prophylaxis to prevent the attacks. So treatment, usually if it is mild, we give paracetamol. Paracetamol doesn't settle, we can give NSAIDs like ibuprofen, naproxen, etc. This also doesn't settle, then we have sumatriptan. Sumatriptan is a 5-HT. 5-HT is serotonin receptor agonist. Remember, sumatriptan is used for both treatment and prophylaxis. Prophylactic treatment in migraine is very important. At least remember the drugs. Beta blockers are used. Antidepressants like amitriptyline, nortriptyline are used. Anticonvulsants like venlafaxine or nalprate are used. And CGRP antagonists may be favorite questions. Calcitonin gene-related peptide. So calcitonin is an important hormone in endocrinology. It also comes here. Calcitonin gene-related peptide. So erinumab. Okay. Rimagepant. And we have calcium channel blockers like flunarizine, candesartan, memantine. Then transcranial magnetic stimulation is a procedure, and botulinum toxin. It's a derivative of botulinum toxin type A. Right? So at least remember some drugs which can be used for prophylaxis. So we discussed about tension type headache. We discussed about migraine type of headache, its treatment and prophylaxis. Now cluster headache, and it's related because cluster headache, paroxysmal hemicrania, SUNCT or SUNA. SUNCT is severe unilateral neuralgiform cephalalgia with conjunctival injection and tearing. See, it's easy to remember cluster headache. Cluster means it occurs in clusters. It comes for 3 months together in a particular year. Then it suddenly disappears. In the next year, in the same season, it comes again. It is stabbing type of pain, excruciating type of pain. Okay, it is not a throbbing headache, it is excruciating type. And see the time duration, 15 minutes to 3 hours. Migraine is 4 hours to 72 hours. But cluster headache will get over before 3 hours. So any headache less than 4 hours is not migraine. So 15 minutes to 180 minutes is cluster headache. Paroxysmal hemicrania is again excruciating unilateral type of pain. It will be lasting for only 2 to 30 minutes. It is even less than that of cluster headache. SUNCT or SUNA is for seconds, 5 seconds to 240 seconds, just sudden unilateral, it comes and goes. Usually for these things, these three are called as trigeminal autonomic cephalalgias because autonomic features like redness of the eye, okay, tearing of the eye, nasal discharge, etc. will be there. Okay. So cluster headache is treated with oxygen. Please remember that. Either sumatriptan injection, sumatriptan nasal spray or oxygen. And prophylaxis via verapamil, topiramate, melatonin. Remember verapamil is very specific. Topiramate and melatonin come in both migraine and this one. Paroxysmal hemicrania is treated and prophylactically treated and prophylaxis given with indomethacin. SUNCT and SUNA is very short, only 5 seconds to 240 seconds, but it occurs for 3 to 200 times per day. So here we give lamotrigine, topiramate and gabapentin. See, here is what we given. For episodic cluster headache, we give verapamil, galcanezumab, occipital nerve injection and prednisolone can be given. What is the treatment for cluster headache? Oxygen or sumatriptan injection. Long-term prophylaxis, we give verapamil, melatonin, topiramate, lithium and gabapentin. Okay. So try to remember these different types of headache.